Good afternoon, everybody. Welcome to this episode of Carney Conversations. And I know people are still coming in, but I'm just going to kind of give a kind of a quick introduction. I see the attendee. Okay, so this topic that we are very excited to be talking about is generally in the area of kind of health disparities in the brain. And I'm joined as with Chris Moore, who's the Associate Director of the Carney Institute. I direct the Carney Institute. And we have two guests that I will introduce momentarily. But just wanted to thank everybody for being here. And I want to remind you all that, you know, the fun of this, of course, is to get questions from you, the audience. And so we really encourage you to take a moment at any point during the conversation discussion that we'll have here to post questions in the question and answer toggle that you see at the lower part of your screen. And Chris and I are going to take a look at those, and we'll kind of intermingle our very long questions also with questions from the audience. And so please really feel free to participate. We would really love to hear your thoughts, and we'll pose questions to our guests. So an incredible delight to really welcome two fabulous scientists. And I'm going to introduce them each in turn. So Dr. Monica Rivera-Mindt. Welcome, Monica. So Monica is the past president of the Hispanic Neuropsychological Society, a professor of physiology, Latin American Latino Studies Institute, and African and African American Studies at Fordham University, with a joint appointment in neurology at the Icahn School of Medicine at Mount Sinai. Monica is a board-certified neuropsychologist, and her research, known nationally and internationally, focuses on the intersection between cultural neuroscience, neuropsychology, health inequities, utilizing a novel community-based approach. So Monica, we're really looking forward to talking with you, so welcome.
Thank you.
Joining Monica is Dr. Diana Grigsby, also phenomenal scientist, wonderful person. And Diana is an associate professor of behavioral and social sciences and of epidemiology at Brown University. Diana Grigsby's research seeks to capture complex processes in the food, social, and built environments to facilitate a better understanding of their influences on what has been coined the 3 pillars of health: diet, physical activity, and sleep. And Diana, so just an absolute pleasure to have you join us. We should mention, of course, that our last Carney conversation was really focused on sleep. We thought it's just like a fantastic dovetailing with the work that we're going to have you talk about. Yeah, you're very welcome. So as we like to do, you know, is to get to know you both just a little bit better. And so I'll start with Monica, but I want each of you to kind of answer this question, which is really, you know, you are incredible scientists. That's why we have you on today in your own right. But a theme, I think, of your research is really thinking beyond, you know, your peers. Like, what is the future of the research that you're doing? And reaching into communities to partner with them to really learn from them so that you are better scientists, and so your work is so much more impactful, and that you also are doing a phenomenal job of really amplifying those voices which often are not heard. And so just love to hear, Monica, to start with you. What was your path to who you are now? What was your career path? How did you become a scientist, and what motivates you, Monica?
Oh my goodness, thank you so much. That's such a great question and a fun question to talk about. I don't talk about that too much. I guess I could start by saying I've always loved science. Once I learned, that science was a thing that we could do, I was really interested. In fact, I think it was my third grade teacher got me connected with George Washington Carver. And I learned about all the things you could do with peanuts. And he was also a Black scientist. And as an Afro-Latinx, kid growing up, the idea of a Black scientist doing work that could really, transform the world was really impactful for me. And as I went on through my education, and I will be very transparent, I did not go to the best schools. I grew up at times unstably housed, food insecure, to speak about diet issues. And so what was on my career path down the line was not clear, but I did know that I was really interested in working with people, helping people. My father and my grandfather are also both evangelical ministers, they're Pentecostal ministers. So this idea of service and being connected to your community is also something very deeply held for me. And by the time I got to undergrad, I became interested in neuroscience and psychology and started following that path. Wasn't sure what I was going to do with it. But in the end, I decided to eventually, after living all over the country and having my own family experiences with dementia in my own family, and having been a part-time caregiver to my grandfather for respite at times, and seeing him, he suffered from vascular dementia, and also being a part-time caregiver for my grandmother in my teens. All of that was very formative. So there were these threads. So I was interested in science. We had, there was this kind of deeply held kind of commitment to serve others, and really, quite frankly, felt disconnected with the medical system, the healthcare system. For me, growing up, that was a big, scary system to even think about. For many reasons, going to a hospital was a scary proposition, going to a big medical center. And we didn't always feel welcome there. My mom didn't speak English. And so, I would end up being the kid interpreter. And so all of these strands and experiences really, I think, were playing in my mind and in my heart as I started thinking about what I might be able to do, as it became clearer that I could pursue a career as a scientist. That is something that wasn't, out of reach for me. And in fact, when I was working, so I've lived all over the country as well. I've lived in the span of 8 years. I've lived in all 5 regions of the continental United States. I would also love to check out Alaska and Hawaii, but haven't done that yet. But when I was living in North Carolina, I was doing case management and in-home family therapy for children and families with severe emotional and psychiatric disorders. And what I saw there was so profound in terms of some of the health disparities in a way that I had experienced, my family and I, but also a level of deprivation that I didn't even know could exist, like working with people in the Appalachian Mountains. So these aren't even Black and brown people per se, but people with such profound poverty. It was like the poverty my mom talked about. My mom's originally from Colombia. And, she didn't have shoes and growing up, and she was only able to finish school to the 2nd grade. And it was that kind of poverty that I saw in our country, in the Appalachian Mountains. And that was really powerful for me. And that really motivated me to start trying to understand this connection between brain health and which I had witnessed in the children and families, where these kids had these really complicated psychiatric and cognitive presentations, and connect that with my interest in working with adults and older adults. So I went to the University of Nebraska. That's what brought me to the Midwest, did my doctoral training, and eventually, traveled around the United States more, and ended up here in New York City. So I bring greetings from Harlem, where I've lived and worked and done my research and sent my kids to public school for the last 20 years. This is where I learned about doing community research, because I will say, even though in my heart, I had this interest in working with communities and with people who have not been represented in research and really in our health system in a real and meaningful way, I wasn't trained to do that work, right? So I got great scientific training, but it wasn't to do community-based or community engaged work. And but lucky for me, I went to Mount Sinai, to the School of Medicine, where I have a joint appointment in neurology, and I connected with the Center for Multicultural and Community Affairs, CMCA, and they kind of scooped me up and really helped teach me about what it is to do community engaged work. I had gotten a K award to work with Latinx individuals in East Harlem and El Barrio, and I thought that participants would knock down my door since I'm, because I'm part of the community, but that wasn't what happened, and it was because I was going about the research all wrong. And I want to amplify this to make sure everybody there who's watching this now, later, whenever, connects to this. So here I am, an Afro-Latinx Indigenous scientist doing work with a good and full heart in my community where I live, where I work. And it was like crickets, and I couldn't get anybody to come to my study. And it was because I wasn't really engaged with the folks that I needed to be engaged with the key community stakeholders. And I had to earn their trust. It wasn't enough that I was from the community, that I lived there. I had to be part of the community and understand what they needed, to be schooled by them. And that's exactly what happened over the course of a number of years. So I got didactic training. I'm formally trained to do community-based participatory research. And over the years, what I learned was go into these community-based organizations, keep your mouth shut, keep your eyes, ears open, and go with the spirit of giving. And I started getting to know people, let people get to know me. I did so many community, educational presentations. I started doing research capacity building centered on their needs, not mine, for my research. And after a couple of years, folks started saying, okay, well, Doctora, why don't you tell us a little bit about your research? And then we really, truly started collaborating together, and it was transformative. And I'll just say this, I know I'm talking a lot, but I feel very passionate and grateful about this experience. I learned so much from the community, and they really kind of started changing the way I think about research, about the questions I ask, certainly how I do this work, with the spirit of giving, not getting. So, I went from what I jokingly call a conquistador approach to research, because that's what I was formally trained, where we get the data, which is the gold, and then we go up to the ivory tower, to do our papers and our grants. I went from that very conquistador approach to research to a true community-based approach, which for me was transformative. It made was I working more hours than my peers? Was I, strapping my kids on to a baby born and a stroller and going to community events, nights, weekends, community meetings, all that, for years and years and years, and I continue to do so. My kids are bigger, but I do that with a joyful heart. But it makes the work joyful and meaningful, and and I get so much out of it. It's certainly more than I had ever anticipated, and it's really taken me to this point of what I really want to do, which is transformative science, not just translational science, but really transformative science, which is centered on the community.
Wow, thank you, Monica. I mean, there's so much to I've learned just from listening to that very short. It was not long. It was really incredible. I know we'll hit on a few of the things that you're talking about. Not least, there is no short-term. There's no shortcut. This is effort. It's on the ground effort. And you need to really have kind of the long game, and it isn't a game, like it really is a partnership. And I think we'll come back to that aspect of what you've both done so brilliantly well. Diana, I know that I'm sure a lot of this resonated for you, but we'd just love to hear who you are, how you got into research, and how you what's your passion, what really is motivating you.
Well, so Monica, there's so much of what Monica said that certainly resonated with me. And I think I'd like to answer the question sort of in a few different parts. First, by starting with, what motivated me growing up as a child. And my father was in the Foreign Service when I was growing up, so he traveled quite a bit. And it was always very exciting for us to see, what he was bringing back from whatever place he had gone to. And so he instilled in us from a very young age that was important to learn about people from different parts of the world, wherever that was. And in addition, my maternal grandmother was was very was someone that was very interested in prevention in her own way. She probably had a fifth grade education, but she walked until she actually lost her eyesight. Some other aspect of age took over, but she really was very adamant about being physically active. And she would drink these tonics and make us drink these tonics that oh my God, we really did not like. But, what I realized is that of all of my grandparents, she was never frail. She was the only one that was always, giving you a firm handshake. She was always up and about doing something. And so I've had this interest. I've lived in West Africa, I've lived in Germany, and I've lived here in the US. And so I've always had this interest in terms of wanting to travel, in terms of whatever it was I wanted to do, but I also had this interest in terms of some aspect of prevention. So public health was very interesting to me, especially as I learned about epidemiology. There's something called the Epidemic Intelligence Service through the CDC. And that was something that I had thought about after getting my graduate training. However, when after I started as a faculty member, I think I really decided what direction I wanted to take after I had my first child. And this was when I realized that I thought I had dealt with sleep deprivation before, but I really hadn't until after I had my son. I was like, oh, so this is what it's about. And then really just started to think more about, what I think about these three pillars of health. My sleep patterns, my child's sleep patterns, what are some of the things that I needed to do to make sure that he was healthy, learning from other mothers about their experiences, and really trying to connect more with the community, and finding also a lot of differences in terms of, talking to mothers, that were immigrants, for example, compared to, say, mothers from the US, but just sort of getting different stories in terms of how, the approach to, to taking care of children. So that actually, I started to think really the importance of, the different viewpoints, where we, instead of just thinking purely in terms of medical terms, because I will tell you, I believe I got some of the best advice. My doctor was great, but I believe I got some of the best advice from actually talking to other women and getting very different viewpoints. But something else that really was very impactful for me was having the opportunity. I had seen a lot of work in terms of I started to look at, the impact of the environment on fruit and vegetable consumption. And a lot of the work that I was seeing in terms of talking about healthy fruits and vegetables were typically, cauliflower, broccoli, what have you. And I had the opportunity to work with a predominantly Caribbean population. And I remember the women saying to me, why are you saying, cauliflower, broccoli? There are other things that we eat, other fruits and vegetables that we eat that are, that are just as good. And those things should be encouraged. And so one of the first things I did was to actually do a study where we looked at availability of culturally relevant fruits and vegetables for African Americans and Latinos. And it was very eye-opening to see the differences in terms of what was available, and really getting a better understanding of the importance of culture and how that really drives what people eat, and understanding more the relationship of food, how people think about food and how that influences health. It really forcing me to think about, okay, how am I approaching this? I really need to think about, that one that is, one size fits all, in that it really needs to be tailored. So that was one thing that really, really informed my work in terms of really thinking more of a culturally relevant approach, talking to people that are actually in communities, getting their perspectives, respecting their perspectives, because there's so much that you come in, and thinking, well, okay, I've been trained in this area, but you haven't lived the lives of the people that you're working with. So it's really important to take the time to get to know who they are, what's important to them, and what drives them. And so a lot of my work now has shifted more to focusing on access to green space and how that influences mental health and sleep among children. And even that has been a very, recently got an R1 to work on this. And it's been important to me to also talk to people that live in the community and what their perspectives are. I may think that green space is important, but they're very valid concerns where people are saying, well, if I do green my neighborhood, what does that mean? Will I still be able to live here? How do we think about practical solutions? While this is a great idea in theory, what is that ultimately going to mean for my community? And so, as I said, in terms of always having appreciation for learning about other people, being respectful about other people, I've brought that same mindset to the work that I've done. And it has served me very well with respect to work that I've done in Uganda, as well as in Ecuador, where I really try to take the time to get to know the communities that I work with before I actually start to do my work, really see where they are, and really try to work with them. And thinking also about language. I think a lot of times we say, for example, participants. And I think we need to maybe change that to collaborators, really communicating more and saying, we really want to work in your community. This is what we like to do. This is what we're thinking. Does this make sense for you? And really working, and it takes a long time, really working with the community in terms of thinking about how we frame those questions, I think is really critical. And I think it's only informed my work. And so I look forward to talking more about this.
Great. Thank you so much, Diana. I'm going to, Chris, would you like to jump in here? Yeah.
I only have 70 or 80 questions, but I'll ask only. I'll try to stick to our script a little bit. This is really, really awesome. Something that, that there's a notion that collaboration in general, if you're collaborating across any kind of, if you're bringing people together that aren't usually involved together in the process in any way, there's really good evidence, for example, even at the level of something as silly as citations, that it powerfully drives increases in citation rate. As like paper after paper has shown this again and again. And it's really interesting to think when the collaborators, as you're putting it really nicely, are also what we used to call participants, just how that's enriching the science too. And it'll be interesting to know how, maybe there's some nerdy metrics way to get at that. I'm sure you're oriented to that. So one topic that both your work touches on is that, how does disease and health and, be it what is probably non-contagious diseases like Alzheimer's or dementia, although there can be a component, I guess now, that's what we're hearing, but also things like, food selection, food opportunity, access. So that there is known to be a higher incidence of dementia, for example, among African Americans, Latinos, and Hispanics, and in numerous other disorders compared to whites. So how, in thinking about disease prevention and diagnosis and care, they're all greatly influenced by socioeconomic status and cultural factors, right? Which is part of what you're already saying. Can you give us just examples of how your work fits with health disparities and the root causes known of this increased burden? Like, start to get us up to speed, or from your very specific perspectives on that. I guess we could just keep going in the same order if you want to go first, Monica, but it'd be great if you both could shed some light on that.
Sure. So I'll go first, then Dr. Grigsby, and then you go. So in terms of my research on this intersection between cultural neuroscience and health inequities, so the ultimate mission of my research is to better understand, the mechanisms and the drivers that are impacting, these brain health inequities, and how we can intervene. What are the modifiable factors that we can intervene upon. But to do that, first, we need to make sure that we have samples that include the individuals that we're interested in understanding, right? And to date, so let me take a step back. What the literature suggests so far is, as you said, Latinx, Black African American, and we don't have great epidemiological data on other populations, but American Indian, Alaska Natives as well do have a higher prevalence of sick, but we'll just focus on Alzheimer's and related dementias now. So for Black and Latinx individuals, it's up to, let's say about up to twice the rate of Alzheimer's compared to non-Latinx whites. And when we think about why that may be, I'm a systems thinker. And so, my work looks at this issue at the biological level, the psychological level, and the sociocultural level. So I have an R1 right now where we're looking at all those different levels of analysis. So we're investigating at the biologically, of course, cardiovascular risk factors, which is very connected to the work that Dr. Grigsby is doing. Where we are actually doing sleep studies. We have the special watches to do sleep, as well as physical indicators. We're looking at diet, looking at cardiovascular risk factors more broadly. And then at the psychological level, we know that dementia can be impacted by psychiatric factors as well. So individuals with a history of depression, for instance, may have a higher risk of dementia. So we're looking at psychiatric factors like that as well. And then at the sociocultural level of analysis, we're looking at discrimination, stress, for instance, socioeconomic status, life adversity, and a whole host of sociocultural factors as well. And then thinking about how those intersect all together, both on brain outcomes, so where we're doing neuroimaging studies, looking at structural and functional neuroimaging longitudinally, and also cognitive outcomes. But also, I just want to note that when we think about these different relationships and how they could impact health behaviors, quality of life, that taking this very culturally informed lens, we're also interested in trying to understand, for instance, how acculturation, how identified an individual is with the majority culture versus their culture of origin, how that might impact some of these relationships, or things like quality of education as well. So we're taking a comprehensive approach to understand this with the goal of being able to, reduce that prevalence, reduce that incidence. But first, we need to make sure that we're getting diverse participants into all of our studies and into clinical trials, which is why part of my work is so focused on really addressing the external validity of our science, of dementia science. So I'm very, happy and proud to be a co-lead on the Alzheimer's Disease Neuroimaging Initiative, for instance, ADNI3, which in this third wave in the last 2 years, we did a really big effort with our ADNI Diversity Task Force to increase the representativeness of the ADNI cohort, with really great effect, taking this community engaged approach, but both boots on the ground as well as more novel digital community engaged approaches, and doing similar work actually with folks at Brown, with Steve Salloway, Tara Tang, and others there, and really with other initiatives as well. So trying to address the representation issue, but then making sure when we bring people into studies that we have the appropriate measures, the appropriate methods, the appropriately trained staff and team, so that we can welcome and do a culturally appropriate or responsive job once people come in, so that they're not re-traumatized when they come to our studies.
Thanks for that.
Oh, sorry. So I was just going from a broader public health perspective. We think of a health disparity as a difference that is a consequence of some social or economic disadvantage. And so one of the things that's important in my work is to make sure I understand what those social determinants are. And those social determinants can be, everything from, looking at policies, for example, related to long-term policies related to housing, as an example, where you had a policy such as redlining that disproportionately affected African Americans living in neighborhoods that made it difficult to, neighborhoods that were not invested in, neighborhoods that had limited resources. And the reason that racial residential segregation is very critical is because we know that housing is one of the major ways that you build wealth in the US. And so one, if you are in a neighborhood where it's difficult for you to build wealth, that makes it difficult for you to pass on resources to, to your children. In addition, we know that the tax base is very important with respect to what supports schools in an area. And so again, if you're in a neighborhood where the value of the housing, where you don't have high housing values, the schools are not going to be very great because you don't have as many resources in terms of supporting that school or supporting schools for the kids in your area. And then in addition, it also makes it difficult in terms of investment in that particular neighborhood with respect to access to resources, whether that's, maybe having more parks, having more grocery stores, as an example. So one aspect of my work has really involved using tools from geography, such as geographic information sciences, where I look at issues around accessibility to food stores. I look at accessibility to recreational facilities. And this goes back again to, if we are going to tell people to be more physically active, if we are telling people to eat more healthfully, but they have real challenges getting to these resources, then, then we are telling them this is what you need to do, but clearly we aren't addressing those barriers with respect to them actually getting the resources that they need to be able to be more helpful in several ways. So one aspect of my work has looked at issues of accessibility to food stores. I've also looked at differences in things like marketing. What kinds of things are marketed to people in stores? And surprisingly, or unsurprisingly, have found differences in terms of what kinds of marketing I see based on whether a store is located in a predominantly African-American neighborhood compared to a predominantly white neighborhood. There's some work that we did in Illinois, where, for example, you might see more marketing around things like tobacco that clearly influences health. So really thinking, thinking about the health disparities, but going, really thinking about what factors, what policies might be driving these health disparities, and how, and it's harder to look at it that way, because one, getting the data, sort of thinking about how to link up, sort of where people have lived historically and whether you still see the same impacts. So that's one aspect of my work that's really important in terms of thinking about the health disparities, thinking more about these structural policies. There's a colleague of mine in the School of Public Health, Medina Ajanor, who actually is developing, she actually wrote a paper recently where she's developed a database looking at aspects of structural racism and how that influences health. And interestingly, she looks at things like voting rights. How does voting rights ultimately influence health, in terms of who's allowed to vote, how easy is it to vote, looking at things like sentencing laws, and who gets incarcerated based on what those laws are. And then also looking at what kinds of fair housing policies do we have in terms of influencing where people can or cannot live. So for me, in terms of really getting at why I'm seeing the disparities with respect to things like, obesity, differences that we see in sleep. We know people who live next to Airports are always complaining about noise pollution, right? And so really getting a better understanding of what are some of the policies that have been put in place that are responsible for why we're seeing these health disparities, and thinking about ways to incorporate that with respect to the analyses that we do. So the current work that I'm doing, looking at access to green space, we are being very intentional in terms of our sampling methodology with respect to being able to recruit not only making sure that we're recruiting a racially diverse group of children, but also looking at some of those environmental factors like, green space access, in terms of ensuring that we can look at what are those and be able to look historically at why we might see the differences with respect to what's going on.
Wow, thank you both. This is really the, again, I wasn't joking about the 70 or 80 points questions. There's such direct contact. I just want to make a quick observation. There's such direct contact to a lot of work that goes on in the neuro department here when people are doing, say, mouse studies or fly studies, or studying model organisms, especially around stress is one place, but sleep also. Like there's really, those are both incredibly rich topics for research ongoing at that level that to me always comes up with these really surprising outcomes, like the effects a colleague of ours, Kevin Bath, has done a variety of studies, but others have as well, on early life stress and how that'll impact genetically other generations. And then you start thinking about the comments you're making about policies that happened 50 years ago can maybe, I don't know that this is true, but your research could inform it, right? Could be impacting us now also. And that's a factor. So Diane, over to you.
Yeah, thank you, Chris, and thank you both. I want to go back to Monica, your reference to the ADNI project, and I just that's the Alzheimer's Disease Neuroimaging Initiative. Okay, and and
That's right.
you're leading part of the Diversity and Resilience Core. Is that
right? So
yeah.
I'm co-leading with the wonderful Ozioma Okonkwo from University of Wisconsin, Madison. We're co-leading the new engagement course for which will be moving into ADNI for, assuming funding for the renewal goes forward. But for ADNI 3, but it's looking really positive. But
I have no doubt.
Yeah, but for ADNI 3, we started really ADNI 3. The diversity task force started as a pilot study, really like a proof of concept, like, could we do this? And the great idea, and the PI, Dr. Mike Weiner is truly so visionary. And when he pulled us together to really, ask the question, if we could really truly diversify such a huge study. For those of you who don't know about ADNI is one of the biggest longitudinal cohort studies in the country, in the world for Alzheimer's, and really an important study that informs clinical trials. So it's a really important thing. It helps identify biomarkers to inform clinical trials, which is really important. And the question that we came to and asked is, if we can make ADNI a more representative study, if we can change the paradigm in this really big monolithic study that has about 60 sites, then we could really make a big impact on the field. We could inform clinical trials that could inform, disease modifying treatments and ultimately cure, right? Because we're not going to have treatments and cure for everyone unless folks are of all backgrounds are included in these studies. And so it was a kind of a crazy ask and a big, a big idea. It's almost like Don Quixote-esque, I feel like, as I reflect on the journey of the last 2 years. But we've been working really hard. We've had 13 sites as our kind of testing, pilot sites, including Brown at Butler, with Dr. Steve Salloway and his group, and everybody has been so game. We've gotten such support and buy-in from these, huge investigators who I kind of can't believe I'm working with some of these people, but yet we're working together, true team science, and with the efforts and interventions that we've made to really transform this into a more community engaged approach. We went from these 13 sites recruiting about one ethnoculturally diverse participant per month, per site per month, to 4, to going from 1 to 4. And that's how you make change. So talk about structural changes. And Dr. Grigsby, I just loved hearing you talk about the structural issues that we have that are decades, centuries long, right? What we're dealing with, and trying to dismantle in many ways the entrenched structural racism in science and dementia science to make these kinds of changes. It's really exciting to be part of, and there's a lot of work to still do, but we're beginning to make some inroads, which I feel really energized and excited and grateful to be part of.
Well, thank you, Monica. I want to actually pose a little, so this was exactly on exactly what I wanted you to kind of explain. And I actually, there's these numbers, I think what you said in terms of impact is the most important, but I also read that there's over 4,000 publications have resulted from the ADNI initiative, and that's extraordinary. I mean, just like enormous impact. But I want to come back just really quickly to, like, I think for a lot of us, and I'm sure people listening to this, is like, how did you stay in this, and how did you get early funding, and how did you get people to, it's just like this, the long arc of what you're doing is just enormous, and it has to be that way, like that's the whole point. But could you just, like, how did you get support, early funding to do this? Now you do, now everyone's like wants to partner with Monica. Like, I think that, but like, how did you get this going? Like, when, I'm sure that there was skepticism and we're never going to do this, and the outcome is going to be a long time, like, it's like
right,
long-term gain. Right. Like, what was the funding like, and how did you pull this off?
Listen, so it's so the arc of history and science is long, and it's not always in a direct linear line. And I would love to hear Dr. Grigsby experience with this as well. But I will tell you, when I started doing this research, so now almost 20 years ago, not with ADNI initially, but I'm so glad to be part of ADNI more recently. But there wasn't quite the appetite for this kind of research, and people were talking about it, and people agreed that it would be an important thing to do. But I really don't think that it kind of was internalized as an important priority until we all as a society experienced George Floyd, quite frankly. And there was this cumulative effect of so many injustices and so many inequities, including COVID, the profound impact of COVID, kind of alongside this structural racism pandemic as well. But before that, for most of the entirety of the rest of my career, and still to this day, it's hard. It's a struggle. The struggle is real. And I've gotten so many, rejections and no's for all the yeses people see, and for all the work or the publications that I have. There are so many more no's, so many micro and macro aggressions that I have experienced, that I continue to experience. And even like in this last funding cycle, the same week that we found out really good news about the score for ADNI, an R1 I submitted that's directly related to everything I just talked about went unscored. So let me just I just want to be very transparent that this, the struggle, it was maybe harder before, I will agree, but continues to be really hard, and a struggle, and doing work that's disruptive is not easy, because these are big asks that we're trying to push forward. And it took, again, it didn't take days, didn't take weeks, didn't take months. It's taken years, decades, centuries to get where we are in terms of the poor health and the poor brain health of our country for certain constituents of our country. And my mission is to try to make everybody have the same chance for good brain health as they move forward. And that's, hard, but getting to have conversations like this with amazing scientists like Dr. Grigsby re-energizes me. And if it weren't for these kinds of opportunities and spaces in my own sister circle of my Black sisters who we meet very regularly, I don't think I would have the energy or the ability to keep going some days. But then I get to work with community members, collaborators, participants, and have these conversations, and I find it very energizing. But what about you, Dr. Grigsby?
Thank you.
Can I be an interviewer?
No. Please. That's
Yeah.
exactly where I was going. Yes, absolutely.
I would love to hear what you think about what it's been like over the last, 10, 20 years and what it's like now for you.
Yeah. I mean, what I will have to say that in terms of being able to do the work or the disruptive work, as you put it, certainly isn't always what you're advised to do. Especially when you're starting off. And I will say that even me, with the current work that I'm doing, adding a scale on everyday racism was probably something that I might not have done before. I do think that, and I also have a lot of colleagues that have really tried to work in this space for a very long time, that are only now getting duly recognized. And for some people had to pay heavy prices for really focusing on, really looking at things like, structural racism, studying structural racism and really tying that to health. And the truth is, I think definitely, I think COVID really sort of all of us having the collective attention at the same time, looking at what were, the disparities in COVID and who was really being impacted by COVID made a difference, in addition to George Floyd, because I think many of us knew these things. I think it was another thing to actually be able to see it. And certainly, I think after that, we really started to see more, I would say more of a shift. I would say more of an acceptance that maybe this is something that we needed, that we should be exploring in our work. And it's certainly been evident in one, I think Health Affairs, I'm thinking about the journals that we usually read in my field, recently dedicated an entire issue to structural racism from various perspectives. I don't know if you all, the JAMA actually had an incident last year, or I believe it was last year, where they had put out a podcast where basically we're saying, where the folks of the podcast are saying structural racism didn't exist. And it ended up being this whole thing where the editor had to step down. And now I think for the first time in JAMA's history, there is now, I think, an African-American woman has been appointed as the editor of JAMA. I think this only happened in the last 24 hours, but so I think that clearly what happened within, the last few years with COVID, it's so sad to say the last few years, I'm like, wow. And, it's still ongoing. I think that has created a space where people can more readily talk about some of the structural issues related to health that hasn't been there. And I think for one of the first times, the NIH actually had a call that specifically was looking for proposals related to structural racism. I think one of the first times that they had done that as well. So I think there certainly has been more opportunity and more of an appreciation. I don't know how long this is going to last. I don't know whether this will continue to be the case. I hope that it will be, but at least for now, I think, the thing is to just enjoy this particular moment. But I'm hopeful, but I really don't know how long this will last. And I'm just being honest. Because
preach.
there's just certain work that just hasn't been appreciated. And many of us have
Right.
had to be very creative in terms of how we frame our work to be able to get funding. And often, having to rely sometimes on private foundations, look for other organizations that we're willing to fund unusual work that maybe the NIH wasn't quite ready to fund. And that's, another thing that people have done as well, with respect to thinking about, other sources of funding in terms of being able to at least get some of your work out and hope that, you get it, you get it out and someone sees it and then you can apply. But I really don't know how long this is going to last. It certainly is a shift. And I think there were many of us that wanted to do this work, but we were concerned about being able to get funding. I am really happy for a lot of my colleagues that were already working in this space and happy to see that their work is being cited and being appreciated.
Yeah.
Thanks.
Thanks, Diana. Chris.
So Monica answered a question that I was just about to ask, because I think it has a lot of different components to it, but you're answering the question about, one of the barriers to really getting access to the broad population we need to, if we're going to make statements about health that are broadly applicable, is differences in language. So non-English speaking, at least here in America. But so again, you partly answered it, but that, Diana, that feels like it really touches in your work too, where you're traveling abroad. Obviously, when you're traveling abroad, you have to have the capacity to communicate with your collaborators. Can you reflect on some of the strategies that are most effective in doing that, but also some of the strategies also in America, maybe reaching out to non-English speaking communities? It feels like a really important, this is a question that got posed in the Q&A, and it feels like a really important component of this.
Well, one thing that for me, I think whenever you're going to work with any community, even if they're English speaking, is one to really think about, if you are trying to initiate a relationship with the community. And I think the way that we approach our work, the thinking, the mindset, it is very important. So I think that if you are, and I think this harkens back to something that Monica said earlier, where she was going to the community and say, okay, well, I can just come in, and do the work, right? I think that one of the things that we have to keep in mind is that we need to think about this more when we're deciding that we're working in the community. Think about it more, one, as a marathon instead of a sprint. And then two, think about it as a relationship, right? And you're hoping that it can be a long-term relationship. So that means that there's certain things that you need to do in terms of building, the scaffolding you need to do in terms of building that relationship and making sure that the relationship is sustained. And so I think if you have that mindset, if you do know, so I'll talk a little bit about some work that I've done in Ecuador. One of the first things that was one critical piece was I was fortunate. I had a colleague who was a medical anthropologist, and he had worked with indigenous communities in Ecuador. He had worked with Afro-Latino communities in Ecuador, and he has spent years building trust. And so I went to him and said, this is what I'm interested in. This is what I like to do. And he said, well, this is how I usually work, and I see these as my colleagues. These communities really trust me. And so it was important to me to first ask him, well, what do you need me to do? How do I, this is the project that we'd like to do, but what do I need to be doing? How do I need to carry myself when I interact with this community? And I think that was really important in terms of, one, my relationship with him, but then also making sure that I was keeping in mind the relationship that he had built with these communities and making sure that I was coming in and not doing anything to, spoil that relationship in any way. So once I had that mindset, it actually became much easier to be able to do the work, to be able to go with him. As I said, I think I was telling you all before, I hadn't worked with an anthropologist before, and going, I was thinking, okay, we're going to do a focus group, I'll have my questions, we'll just go in and we'll do this. And it was like, nope, we're stopping at a grocery store. We're taking everything. We're going to make a meal with the community. We're going to eat first. So it took us, it took probably 3 hours before we even got to asking the questions. And what was important was that I had to understand that he is, here's my colleague. He has built a relationship with this community. This is what is important to this community. And that we have to build this trust. And so I have to respect that. And I think that really is the first step, with respect to, working with communities that might not be, English speaking, or any community that we work with. I think the first thing is really understanding that it's a relationship. So right now, another example here in the US, here with work that I'm doing now, is that we are recruiting schools. We're working with schools. And I actually try and call the schools myself and talk to them, because I want them to know, I want them to be part of this. I want them to know that I'm interested in how it works. And I've had some schools say, well, no, we actually think it's better if you do it this way. Okay, well, I guess we need to go to IRB and make that change. And I think the key thing is that once you understand that you aren't just going in and saying you're going to collect this information, but that you really are building a relationship with that community, I think it makes a key difference.
Thank you so much. That was phenomenal. Thank you. I know that you're not going to believe this because we don't, but we have 2 minutes left. I know. There you
Wow.
go. It always feels like this.
That just flew.
When we're just like on this such interesting, important, significant conversations. But I do want to get maybe to just get to one other question from the audience, and maybe we can answer the other one live as well. But I think that this question is really related, and I think connected to a lot of what you were talking about earlier. We know that PTSD and complex trauma, is kind of almost ubiquitous, within the Black, Indigenous, and people of color community. And, are there studies to provide evidence that indicates that trauma can exacerbate kind of existing high risk for Alzheimer's disease? And is this feeding into potentially some of the reasons, early lifehood stress, for a whole variety of different reasons that you've both really wonderfully described? Is there a direct link between stress and Alzheimer's disease, predisposition to Alzheimer's disease risk?
Yeah. Dr. Grigsby, do you mind if I field this one? Yeah. So there has been some interesting work in terms of stress, for sure. I'm not familiar with work on PTSD per se, so I can't comment on that. But certainly there is some interesting work that has been done on stress. And in fact, the CDC has a bold center of excellence with the Alzheimer's Association. Right now, we're working in earnest to put together dementia risk mitigation guidelines for public health agencies across the country, which will be rolling out, hopefully, I think, starting next year, the year after. And we do talk a lot about different, things that we can do to mitigate our dementia risk, including things like, dealing with depression, right? Depression is a risk, becoming more active that is certainly an issue. And, certainly around the 3 pillars, exercise, so important as well. So we're working on that. And if you stay tuned, I'd be happy to come back to talk more about that effort. And if anybody, there were so many great questions that we didn't get to. As an ESL person, I learned English on Sesame Street and in school by the 3rd grade. But if anybody has any questions they want to follow up with me, you can find me on Twitter. You can DM me. I'm at Dr. Rivera-Mindt, at Dr. Rivera-Mindt. And I would be happy to follow up with any other questions that we didn't get to, but it's been such a pleasure. Thank you for having us.
Oh, that is a great offer. Thank you. So this is, we're going to close, and I think we've expressed this just over the course of a very, very short hour, but enormously grateful to you both. I'm really taken with many things that you said, but perhaps sticking in my mind was Diana's comment that, like, this is a marathon, this is not a sprint. The commitment, the drawing from your personal experiences, I think is obviously a piece of, it is who you are, it is your oxygen. That's much of what keeps you going and keeps you in what is a very difficult business of getting funded, particularly for the kinds of studies that you're both doing, but enormously impactful. And so we're so incredibly grateful to you both. I think it's opened our worlds. I hope it opened the world of the participants and those people who are going to watch this later virtually. But my world is more enriched now, and it's really made me much more thoughtful about the types of research we do and how to have an impact. So thank you both.
Thank you. Great to be here. Thanks to Brown Carney Institute.
Thanks
Thank you
so much. This is awesome. Thank you.